Nice break and you're fired up with food in your belly, ready to carry on. This afternoon's session is broken up into two sessions. We have the first session, which will start shortly. We'll then have a short break again before we move on to the final session, which will be launching the new research strategy of the PSPA, and also we will be holding an interactive session where we'd like people to take part, answer questions in a little poll that we put together. So do hang around if you can, and hopefully it's going to be an informative afternoon. I'll now hand over to Nigel, who can introduce session 3. Thank you.
Thank you. Welcome back, everyone. So we'll move straight on to the next session. I'd just like to introduce Alistair Church, who combines primary care with neurology. He works as a GP principal in Gwent, South Wales, and also as a specialist in neurology at the Royal Gwent Hospital, and has long been interested in PSP and other movement disorders. And he's going to just hand over him to introduce the speaker of this session. So Alistair, thank you very much.
Thanks very much, Nigel, and welcome everybody to this afternoon's session. So my name's Alistair Church. I'm a GP in Wales, but about 15-20 years I've been involved with the neurology, particularly movement disorder and PSP and CBD. So I'm thrilled to be chairing this afternoon's session, although I have to say slightly trepidatious after the amazing session this morning. It was fantastic, and thanks very much for all the speakers. It's also fantastic to be involved in a sellout event such as this. I'm sure Wendy had some butterflies this morning when we kicked off, but it just shows what you can do with technology, and I'm sure that this is going to be a blueprint for how we run things in the future. It's great to have people joining from all over the country and beyond, possibly. So that's great. So what we're going to do this afternoon, at least in my session, is we're going to have a couple of talks. The first is on the diagnosis of PSP, CBD, and I think this is crucial. I mean, this is very close to my heart. I think hearing some people's stories about often their journeys and how long it takes to get a diagnosis, I think can be quite sobering in the clinic. And I think it's a very important part of the PSP Association to make sure that we educate physicians about making these diagnoses and being aware of them. So I think that this is really important. So we're going to start off by going up to presumably the frozen wastes of Aberdeen. Diane, are you ready? Is your talk ready?
I am ready, yes. I'll just share the screen if I can.
So Diane's a neurology registrar from Scotland, and she's going to start telling us about the diagnosis and management, or diagnosis at least, of PSP and CBD. Over to you, Diane.
Great, thank you very much. That's screen sharing okay? Great.
Yeah, that looks good.
So yes, so my name's Diane. I'm a neurology registrar up in Aberdeen in the northeast, and also a clinical lecturer in the University of Aberdeen. And it's a real pleasure to be here today. Thank you for the invitation. It's a lovely opportunity, I think, for us to encourage one another and share together and see the inroads we are making and trying to improve diagnosis and care and, you know, of course, ultimately cure in PSP and CBD. And as we've heard already today, we know that diagnosis is important. Improving our ability to provide an accurate and a timely diagnosis is essential, clearly for people with PSP and CBD and their families. It's also important for health service providers because diagnosis influences our counts of the number of people with PSP and CBD. And then also clearly for researchers, particularly for early and accurate diagnoses for people involved in clinical trials. And many of you, I suspect, have experienced a lengthy process or pathway towards diagnosis. for some, that may have occurred many months after the onset of your symptoms, and may also have occurred after you had received another diagnosis like Parkinson's. And despite us knowing about these difficulties, few research studies have very systematically and in detail described the diagnostic journey from first symptoms through to a final, unchanging, unrevised diagnosis of PSP or CBD. And as you can see from these couple of diagrams, and please don't feel the need to look at those in detail, it is a complex process. There are multiple different components to it, both before the first contact with a healthcare professional, the diagram on the right, but then also a complex process afterwards. And if we want to try to improve the diagnostic journey, we have to first try to describe it and to measure it. And to do this, multiple approaches in different settings, using different methods are the best way to try to achieve a thorough and a systematic understanding of the vulnerabilities in the diagnostic process, and in particular to try to identify where we could make improvements. And what I'd like to do this afternoon is to share with you some of the things we've learnt about the diagnostic journey from measuring that process in two different groups of people with PSP and CBD. What I will say is that the results and findings I'll show you are unpublished, so they're not yet peer reviewed. So this is very much a taste this afternoon. So the first group of people we looked at diagnosis in is a group of individuals who were recruited to the PINE study, which was a study of newly diagnosed people with Parkinsonism, so this collection of symptoms, of which PSP and CBD are one cause. And they were identified over a period of 7 years and then followed up over the course of their life. And in these group of individuals, I looked at their GP records, their hospital records and their research records, and tried to pull out as much detail as possible about the diagnostic journey. From people's very first symptoms over their life course. And then the second group of people we've looked at is a more recent cohorts, the Scottish PSP and CBD cohorts. And this is a group of people with both new and existing diagnoses of PSP and CBD, as well as their carers, which were recruited over an 18-month period up to 2019. And as part of the buried aims in this study, one of the things we did was to ask people with PSP, CBD, and their carers to reflect on their diagnostic journey and describe that for us. So if we, first of all, let's start at, I guess, the very start of the diagnostic process. And what I just wanted to say first of all was to just describe the study in a little detail. So, this was set up during my clinical academic fellowship, which was funded by the PSP Association as well as the Chief Scientist Office of the Scottish Government. And as I've mentioned, both patients and carers were recruited. There were a variety of different study aspects and also an element of inviting carers to participate along with their family members. But the first thing I wanted to discuss from this cohort was when and why people with PSP or CBD, why they first seek contact with a healthcare professional, and trying to quantify that. And this is a component or period of time in the diagnostic journey we can't establish I guess, medical notes or medical records. So the only way we find out about this is by asking people with PSP and CBD, asking you these questions. So some of the things we find, again, I don't expect you to look at the diagram in the right in detail. What I just want you to appreciate broadly is that in this period, there are multiple phases of decision making. And each of the triangles in this diagram represent a different phase. And the first phase to look at initially, which has been labelled in this framework as appraisal delay, is the time between when somebody first notices symptoms and then when they conclude or attribute those to illness. And what we find is that this period of time is longer for people with PSP compared to those with CBD. And similarly, a lower proportion of people with PSP than with CBD suspect illness when they first notice their symptoms. And when they do conclude that symptoms are due to illness, this is, in terms of themes, this is largely due to the specific symptoms which people experience, the fact that symptoms persist or that they progress. The consequences of symptoms is also very important. So where people have noticed balance difficulties and then have falls. And the other thing that leads people to suspect illness is a suspicion or a concern about another neurological illness, such as motor neuron disease or multiple sclerosis or Parkinson's disease. In people who didn't initially view their symptoms as serious, symptoms were thought to reflect normal body changes, stress, medication side effects, trivial illness, or in fact that people just hadn't noted the symptoms to be out of the ordinary. The ultimate conclusion that symptoms might relate to illness was again largely due to symptoms and themes there. Safety concerns was quite common. Again, the lack of improvement or progression, and then the impact of symptoms on day-to-day activities or function. And then what also became clear is that the actions of others, and particularly family members, was critical in coming to this conclusion. If I move on then, so the next thing that we find was that people with PSP decide to see their doctor in approximately 24 weeks, and for CBD shorter at 6 weeks. And that takes us up to the end of the second triangle. Now, if you remember, if we go back to the first stage of when people started to think that symptoms might relate to illness, that was also 24 weeks in PSP and 8 weeks in CBD. So what this means is that the next individual phase, which is called illness delay, and what that's defined as is the time between when people infer illness and when they decide to see their healthcare professional, commonly their GP. That phase is negligible in PSP and CBD. There is no clear additional time delay in that phase. And then the subsequent phase detailed in this framework, behavioural delay, is also negligible, and that's the period between when someone thinks that yes, saying my GP might be helpful here, and then actually making the appointment. I'm not going to outline any more in detail of the diagnostic pathway in this group of patients, except to say that the overall time from symptom onset to diagnosis was about 4 years in people with PSP and CBD. So the point is that as a proportion of the overall diagnostic delay, how people with PSP and the CBD appraise their symptoms, that is a small proportion of the overall diagnostic journey. And what we'll see as I go on to discuss the remainder of the diagnostic journey in the PINE study is that the much greater proportion arises after initial contact with a healthcare professional. And this is notably different to cancer diagnoses, where there's a large volume of research in diagnostic delay, where the really critical public health challenge there is in trying to reduce patients' appraisal of their symptoms and reducing the time to contact with a healthcare professional. So what we're also probably saying is that these existing frameworks and their use is important because it allows us to better compare these journeys in different studies and different settings. But these frameworks probably oversimplify the complex and non-linear process after contact with a healthcare professional. So they're probably not ideally fit for purpose in neuroprogressive illnesses. So if we move on, we continue on the diagnostic journey, and now looking at the PINE study. And as I said, this was newly diagnosed cases identified over a 7-year period. What we did here was we matched each of these individuals with a person with Parkinson's disease who was the same age and same sex. And then we tried to compare the diagnostic journeys and pathways in these two groups of individuals. What I'll say is, and this is another method of looking at diagnostic accuracy, 3/4 of the PSP cases in this study were diagnosed in life. For a quarter, the diagnosis only became apparent after death. And I think that demonstrates that diagnosis is difficult, and even with expert input and the benefit of follow-up over many years, we don't always get the diagnosis right. And I'll come back and speak about that a wee bit more. We had intentionally matched in age and sex, but the people in the two groups were also well matched in other things which might have influenced the diagnostic pathway. So things like education or socioeconomic status or ethnicity, all these variables were well matched. So we were looking and attributing differences to different diagnoses rather than any other factors. And we sought to try to capture a full overview of the diagnostic pathway, to try to compare the time intervals to key diagnostic milestones. So the first was the diagnosis of the Parkinsonian syndrome. So as I said before, this collection of symptoms, of which PSP and CBD is one cause, Parkinson's disease would be another. But identification of that syndrome is a stepping stone to a more specific diagnosis. And then we looked at the time from first symptom to when PSP or CBD specifically was included in differential diagnoses. So this list of possible explanations for someone's symptoms, which a doctor will think about, and then the time to the primary clinical diagnosis. So, doctors felt best explanation for the symptoms that someone experiences. And then we also tried to quantify and summarize the number of different primary diagnoses, the number of different differential diagnoses, and then also the number of changes over time or revisions to diagnoses from first symptom to end of life. So what you see here is the first column where we're looking at the different milestones we've discussed. The second column is PSP and CBD patients, and the third, individuals with Parkinson's, and the numbers here are years. And what we can see with strong evidence of significant differences between these groups, that for people with PSP or CBD, it takes about 2 years from symptom onset until the Parkinsonian syndrome is identified, compared to just over a month, I think that would work out as in Parkinson's disease. To where PSP or CBD is considered as a possible diagnosis, so amongst the list of possibilities, that's about 3 years in PSP and CBD, and about 2.5 months in Parkinson's. To when PSP or CBD was first diagnosed specifically, that's up to 4 years in PSP and CBD. In comparison, nearly 5 months in Parkinson's. And then the final row here is to the final unchanging diagnosis, where there were no subsequent revisions thereafter, and that was 4 compared to 1 year. So there are clear differences in the two groups. And then in this table, if we look at the total number of different primary diagnoses in the first row, and different differential diagnoses, and then number of revisions in the third row, again, we can see that the number of primary differential diagnoses or revisions to diagnoses is higher in PSP and CBD. Pulling that together just briefly to summarise before we move on, we're seeing that individuals with PSP and CBD take longer to reach key diagnostic milestones. They're given a greater number of explanations for their symptoms, and undergo more diagnostic revisions over the course of their diagnostic journey than individuals with Parkinson's disease who are at the same age and sex. So let's look then at another phase of the diagnostic journey, and looking at the transition between primary care, so general practice, and secondary care, so hospitals. And the usual and ideal pattern there is that, of course, that GP makes a referral to an outpatient clinic, and people are seen in an expected manner. But of course, sometimes people need more urgent care and need to present to hospital in an emergency. We know that hospitalisation can expose people to stress or infection, so we ideally reduce that as far as possible. But what we looked at here was trying to see the differences between these two groups in how they first interacted with secondary care. So for how many people was that an emergency attendance? For how many people was it a routine clinic appointment? We looked at then where there were emergency attendances, how frequently did those happen? What were the reasons and what were the outcomes? And then looked at hospitalizations. This is all prior to diagnosis. And then looking at when and where people were referred to in an outpatient clinic setting. And what we found was that for a third of people with PSP and CBD, their very first secondary care contact after symptom onset is an emergency presentation, and that's 3 times higher than in Parkinson's disease. We find that emergency presentations didn't reliably trigger an outpatient referral, and the consequence of that was, for a proportion of people with PSP or CBD, they had recurrent emergency attendances, and those attendances in the whole were significant. Falls leading to fractures, for example, and attending A&E frequently resulted in hospitalisation, and there were clear differences in the duration of hospitalisation, even in this period prior to diagnosis. between people with PSP and CBD and those with Parkinson's disease, you know, I think showing us that even at this early stage, people with PSP or CBD can be slower to return to their baseline level of function than those with Parkinson's. If we look then at in those who were referred to an outpatient clinic, we can see that in Parkinson's disease, in the second column, the majority of referrals go to neurology, whereas in PSP and CBD, there's a wider distribution of specialty input which is sought. If we look at timings, we can see that overall the time from elective referral to secondary care in any specialty, I should say, is more prolonged in PSP and CBD compared to Parkinson's. Specifically, the time to a movement disorder review is more prolonged. And this is essential because the majority of people with PSP and CBD are not diagnosed before they receive this input, be that in neurology or care of the elderly. So if we put that together, full fractures and recurrent presentations to hospital with a subsequent lengthy hospitalization period might serve as diagnostic red flags for doctors. Differential diagnosis in primary care influences where people are referred to and when. And we see that the time to referral and review is longer in people with PSP and CBD. I think the really important thing to emphasize is that reaching secondary care doesn't guarantee an immediate accurate diagnosis. And what we see is that movement disorder input is essential, but that takes longer for people with PSP or CBD to obtain. So that is, I guess, an overview and a somewhat selective overview of the diagnostic journey from symptom onset through to diagnosis. We know early accurate diagnosis is important, and as disease, as the disease modifying treatments we are longing for appear, that's only going to become more important. We can see clearly that diagnosis is difficult, and at present, despite the most expert input and duration of follow-up, we are going to be somewhat limited in our ability, and everyone in life, to provide an accurate and timely diagnosis. But of course, the key thing to say, as we've heard so much of this morning, we're making really important strides forwards in identifying biomarkers, so blood tests or imaging, to try to diagnose earlier and accurately. What I would say as well is that I think there are also preventable or reducible vulnerabilities in the diagnostic process. I think those vulnerabilities are particularly in secondary care, but vulnerabilities which I think are potentially amenable to intervention to improve diagnosis, and of course ultimately care.
Thank you. Thanks very much, Diane. That was great. Wonderful. I'm sure that the what you've just told us chimes very closely with a lot of the stories that the patients who are listening to this, or people with PSP, have experienced. So thanks very much. Yeah, I mean, clearly, if we can diagnose people as early as possible, that's great for them. It's also great if we're trying to look for people that will go into trials. I mean, you often hear the analogy that this condition is like a fire. If you can pick it up at its earliest, you may have a better chance of putting it out, but by the time it's spread, it gets much more difficult. We've got a couple of questions here, if that's all right, if we can just go through quickly, if I can find them. So why is there such a difference in the delay between people with PSP contacting their GP compared to those with CBD? That was something that you mentioned very early on, Diane. Have you got any ideas about why that's?
Yeah, and what I mean, absolutely. And I mean, one of the things I haven't, you know, expanded on here is what symptoms exactly are the first symptoms people experience, and I think there are probably very important differences. And I think one of the key ones is that, particularly for people with PSP, a lot of their initial symptoms are non-specific.
Can I just interrupt a minute, Diane? Can you unshare your screen? So
sure, of course I can. Sorry.
Thank you.
Has that worked?
Or maybe it's just me.
We've got just a blank white screen, haven't we? No, we're still viewing your screen, Diane. Yeah.
Better?
Perfect.
Yeah.
Thank you. Perfect.
Sorry, technology not my strong point. So I think what symptoms people experience at onset is important. So PSP and CBD, they're often more non-specific. For people with Parkinson's, tremor is a very, very common initial symptom. And of course, in terms of, you know, pattern recognition symptoms that both, you know, people, you know, in the community before even speaking to a doctor, attribute as not being right for them. But also I think for clinicians, both GPs and also in secondary care. So I think the symptoms themselves are important in the differences. I mean, I think in terms of, you know, the determinants of diagnostic delay overall, I think there's actually not a lot of research in that, particularly in PSP and CBD. What we see in and again, a limited body of research in Parkinson's disease, a few things that have been suggested are age, or sex, and what we've already talked about, which is the type of motor symptoms people present with. So I think that's definitely an area actually we need to look into in more detail. We were a little bit limited in the PINE study because of small numbers doing that. But I think going forward, if we're going to improve diagnostic pathways, that's an area of research we do need to invest in, absolutely.
Okay, thanks so much. Have we got time for a couple more, Wendy, or should we move on?
I think we've got time for one or two more.
Okay, excellent. Okay, I'll read the next one out then for you, Diane. So assuming that the behavioural changes are the first symptoms of PSP that show up, most GPs, or I can see why I was given this session, most GPs would show one to the door as being too trivial. This cost me many years delay in getting the diagnosis. How is the PSPA educating GPs about early symptoms?
Yeah.
You know, whether you feel happy to answer that, Diane? Or whether we
so I mean, so I think what I would want to say first of all is that I can only imagine the frustration, and from traveling about through Scotland, seeing people with PSP and CBD, you know, visiting them in their homes, and often hearing this story, I really sympathise, and I can only imagine that uncertainty and frustration. I think what I would say, you know, we were speaking about this quite recently, is I guess one thing with GPs is that in Grampian, a GP in terms of Parkinson's disease will see one new diagnosis of Parkinson's in about 3 years. And if we think about how much rarer PSP or CBD is relative to Parkinson's, actually a GP might see one new diagnosis in 10 to 15 years, and this is a bit of a guesstimate, maybe once in their whole working career. And on the whole, though not necessarily always to the ideal first secondary care location first time, what we find in terms of pulling together information from lots of different people is in terms of the overall diagnostic journey, that transition to secondary care is relatively, not absolutely, brief. But I guess what I would go back to and really want to emphasize again is that the experience, the personal experience of that period of uncertainty, I clearly do not know and can only imagine. In terms of Wendy will hopefully keep me right here. Yeah. There was a recent publication for red flags for GPs.
Yeah, I think we are looking at promoting that this Rare Disease Day in February. I think James had something to add here as well, if that's all right, Diane. Is it okay?
Of course, please, yes.
Yeah, thank you. A fantastic talk, Diane. It really is useful to break down these delays that we see and hear all the time. And some are much easier targets to improve than others. I think it's worth noting there's only 500 neurologists in the UK. So once someone gets to a neurologist, then a delay is unforgivable. We really should be targeting them to get that bit of the delayed pathway dealt with. There are tens of thousands of GPs, and they'll be seeing, as you say, one in a lifetime. That's a really tough stage to break into, but perhaps at least further down the pathway, once you hit a neurologist, I think there we could easily imagine delays. Bearing in mind, of course, only half of the people with PSP present with what I might call typical symptoms of the falls and so on. Half present with behaviour and mood or speech and language changes. I just need to broaden people's awareness of what PSP begins like.
Yeah, I mean, from my perspective, obviously, as a GP of many years, I've never knowingly seen somebody with PSP as a presentation in my clinic. So, it is very difficult. And we're always taught, of course, that common things are common. And as a GP, if you think that everybody that comes in your door has got a rare neurodegenerative condition, then you are going to be referring vast numbers. So you're damned if you do and you're damned if you don't, so to speak. But I think there are some absolute red flags. And I think the number of patients taking on board what James said, when you ask them, what was the very first thing that happened? And they'll tell you they fell over. And that should be something that I think, is inexcusable. If somebody is falling over out of the blue, in my experience, it's always in their garden and obviously often back. We should be jumping up and down.
I agree. I think postural instability, that tendency to fall over, I think is not being as well appreciated as it could be as part of this constellation of symptoms, Parkinsonism. And I think if it were, I think that might have a significant impact. Absolutely agree. Yeah.
I wondered about the CBD and whether they were presenting a bit earlier because of the focal nature, as in just one side of their symptoms. Maybe they often may think they've had a stroke or something.
Yeah.
If it's symmetrical, it might not be so. You haven't got the other side to compare to. Yeah.
So absolutely, I think stroke is a concern. I think often tumours are concerns, and that provokes or wanting to seek input. Yeah.
Yeah. Okay. That's great, Diane. Thanks very much. And I'm sure there's a lot more exploration to go into that. So we're going to move on now. So we're going to take you to the other end of the UK, to Exeter, which presumably is slightly warmer, I imagine, Edoardo. So Edoardo comes to us from Italy, and he's at present a senior research fellow in Exeter, and he's going to talk to us about a neuroimaging in PSP CBD. I think it does come a little bit surprise some of our patients that we can't just do a scan and tell them what's going on. Maybe in the future we might be able to, but Edoardo is going to tell us a little bit more about that. Over to you. Thanks.
Can you see my screen?
Yeah, that looks great.
Yeah, okay. Thank you.
Eduardo, your speech is it just me, or it doesn't sound good? Is anybody else getting it?
Yeah, it's a Dalek sound coming through. Sorry.
Would you like to try logging off and on again and see if that makes it any better, the sound?
Yeah.
Maybe we can have a couple more questions while Eduardo is just checking in and out again.
The other thing I would have said about Diane's speech, obviously those figures very much depend on where you are in the country. As James said, the more neurologists with an interest in movement disorder you'd like to think the better the diagnosis and maybe the quicker you'd make it. There are various studies, certainly in Parkinson's, that suggest that if you're diagnosed by a GP, then that is not going to be as accurate as if you're being seen in Queen Square, which is probably not surprising.
I think one of the things there to help that is this awful attitude that there's not, now I hear it so often in referral letters, there's quotes, nothing that can be done. And that really needs to change. There's a wealth of things one needs to try and do to ameliorate symptoms, educate and inform, reduce harm from other medications, and tackle, a dozen different symptoms one by one to chip away at them. And that sense of being, it's really valuable to be proactive in treating PSP. That message needs to be got out, because whilst people mistake that the fact it's incurable means it's untreatable, that's a mistake. But it means that people aren't willing to be bold in the diagnosis and move patients forwards for help.
Can I just ask something here? We all know how difficult it is to pinpoint the specific diagnosis from the earliest symptoms, and it's the delay. It's frustrating, but it reflects a real difficulty in the clinic, particularly in general practice. So when are we going to have a diagnostic test, guys? Because this seems to me one of those really good cases where the clinicians struggle, and we actually do need a blood test. And here you are, you're all working on biomarkers and tau. So when are you going to deliver us a diagnostic test that Dr. Church can then say, I'd like to exclude PSP and CBD, please?
Now that's a question.
I just make a couple of comments actually. So one comment is about the delayed diagnosis, and I very much echo how frustrating it is, and obviously heard this from patients and families often, which I really understand. And often patients say, you're the first person who said exactly what the diagnosis is. This is great. And I always say to them, well, it's a lot easier now because you've had symptoms for 2 or 3 years and things have changed. And actually, by the time someone may have come to my clinic, may have seen a few people before, things have changed a bit, and you see the whole pattern of things. That's very different for seeing something in the very earliest stages. And, from the GP perspective, of course, behavioural change is a very common presentation. But actually, of all the people who come to GP practice with behavioural change, say in their 60s, 70s, depression is a much more common cause of someone having a change in behaviour. So the kind of chance of it being PSP at the outset with some behavioural change is very low. But of course, if they then develop falls, as Alistair says, you need to jump on top of that. They need to be going to a falls clinic, and things become clearer as things progress. In terms of the blood test, there is a blood test called NFL, neurofilament light, which I think is at the stage now. We know that the levels of this are much higher in PSP patients than in Parkinson's patients. And I think this is a blood test that's sort of on the cusp of transitioning to an NHS test, which I think particularly for patients where it's a little uncertain whether they have typical Parkinson's disease or not, I think that will be helpful. I think it's a lot that, again, that's very different from doing screening in primary care because of the false positive, false negative rate that you kind of get in that situation. So it is these tests are always quite situational in terms of what's in front of you. But I think NFL will come in as a blood test that will be useful. So
I wonder if I might just give a little counterpoint to that, because PSP is a rare condition. I think we do, Nigel, we do have a very good test. The best test is the eyes and ears of someone who knows and is interested in PSP. It is very, very accurate. The problem with relying on a blood test for a rare condition is, unless you have the world's best blood test, you will massively overdiagnose it. Your so-called false positive rate is going to be much higher than your true positive rate. Certainly, unless you have tests that are better than any other screening test that we have for currently in use. So I think it's awareness and eyes and ears is a very good screening test, and the blood tests and things, they've been validated, or they've been not validated as tests, they've been shown to be sensitive in well-established disease, but not in those early cases or the difficult cases. It's a really tall order.
Thanks, James. I think Edoardo's back with us now. So, Edoardo,
yes, yeah. How can you hear me?
Oh, much better, yes.
Oh, great.
Coming through beautifully.
Okay, so yeah, thank you for the patience about my internet connection. And yes, first of all, I would like to thank the organizers for inviting me to this very exciting and interesting conference. I have to say this is for everybody that the level is very high. There is some very outstanding research being discussed here, and I'm very happy to be part of it and to participate to this session. So we have seen and heard many interesting presentations, and I would like to take you into this journey about neuroimaging. We've already heard something in the previous presentations about PET imaging, and I will discuss. There's also something that perhaps will overlap with my talk, but I would like to take you into this journey in which we can try and understand what we have seen so far in until the last 10, 15 years, only with the neuropathological examinations. So only trying and check the brains, what we can see now in vivo and how we can use this new knowledge to understand more about the disease, and also to try and develop therapies. That is the most important, the final goal. So what you see here is a picture of a brain in which all the regions are illustrated. And what did the first neuropathologists, so the people that first looked at brains of people that have suffered from PSP after the 1960s. So they saw a couple of areas that were more affected than others, and they tried to understand or trying to recapitulate all the processes that led to those lesions and to those alterations. This is just one of the two main things that they saw. This is the first. Fortunately, a few years later, at a neuroimaging technique called the magnetic resonance imaging, for which you see a picture here on the left, that uses magnetic fields to try and understand the structure and the function of the brain. So as you see here, the reconstruction of the picture of the brain can see with high fidelity and with high spatial resolution what was seen just in the neuropathological examination. So, for example, for the diagnosis, we can see that the area that was most seen as altered in PSP, that is this area called the brainstem, in particular the upper part of the brainstem that is called the midbrain, was smaller than the normal, as you can see here below, and also the ratio, so the comparison of the size of the midbrain upper and the pons, that is the that lies below the midbrain, could serve as a potential discriminating agent, diagnostic agent, compared to other diseases that are similar to PSP. And similar to this, also the aspect of the midbrain on this other in this other picture that is called an axial picture could make things could improve our power to diagnose a PSP and to discriminate PSP from the other Parkinsonisms that, as we have seen before, can be very, very similar and can be challenging to recognize from a clinical point of view, and in this way can lead to delays in the diagnosis. But magnetic resonance imaging can do much more. Now, this is still on the research setting, but we hope that they could improve our understanding also on the clinical setting. For example, we can not only see what is the macrostructure, so the structure at the regional level, but we can also try and understand what is the structure of the brain at a microstructural level. So the single fibers, the single connections that are from one side, from the cells, from one neuron to the other. This, for example, this sequence that is called diffusion tension imaging permits a measure of the white matter, so all the structure that packs the axons, so the parts of the cells that communicate with each other. And we can try and understand what is the microstructural integrity, and we can say, and we can see that in the neurodegenerative diseases, this has been seen also in PSP. There is a derangement of the connections of the in the brain, a derangement, a loss of the density of the white matter tracts and connection, and we can also reconstruct the brain not from an anatomical point of view as we have seen before, but we can also reconstruct the brain according to the shape and the directions of the white matter tract with a technique called tractography. Secondly, we can also try and understand what is the level of perfusion of the brain. We know that the brain is perhaps the region that utilizes the most of the blood flow, and if the blood doesn't flow properly in certain areas of the brain, we can think that in that area, particular area of the brain, something wrong is going on. And with magnetic resonance imaging, we can try and see indirectly how is the blood flow of the brain. In this technique, for example, we use the water, the protons of the water in of the blood flow, or the arterial blood flow, that are tagged in by as they arrive in the brain, and when they deposit in the brain and they are captured by the sequence, and we can have, as you can see below on the right, a map of colors, of which the highest is the degree of brightness of the color, the highest is the level of the blood flow. And we can see, and this is also something that our group has done, not in PSP, but in other neurodegenerative diseases. We can see that from very early on, on the development of the disease process in neurodegenerative diseases, this technique can spot some areas of a local suffering of the brain cells. We can also try and see what is the function of the brain cells. So not only how is anatomically the connection, not only how is anatomically the level of the blood that flows into single regions, but we can also see how one region relates to the other, how they communicate. So not only how anatomically or structurally the brain is, but also how functionally the brain is. And this is very important in neurodegenerative diseases such as PSP and CBD, because not only we see problems in the movement, but we can also spot problems of very high level cognitive features that require some perfect connections between one area to the other. And there is a very high chance that problems in these functional problems in how the cells communicate with each other, not only of how is anatomically the tract, can represent a very early feature of neurodegenerative diseases. And finally, there are two other sequences that can be very, very useful, and they tag some molecules of some molecules that can be altered in the brain. The first one is neuromelanin. Neuromelanin is a molecule that is produced by the cells that produce two neurotransmitters. One is called dopamine, the other one is called noradrenaline. Dopamine, we know that is the molecule, or better, is the molecule that is lacking in some areas of the brain, such as the substantia nigra in the midbrain. The midbrain is the same region that we have seen earlier that is altered in PSP. The lack of neuromelanin, so a lack of the cells producing dopamine, is one very important feature in Parkinson's disease. But it has been seen also that in PSP this can be a prominent area of neurodegeneration. You can see, for example, here below a study published 2 years ago, in which in the center you can see that people with Parkinson's disease have a decrease of the area of the cells producing neuromelanin, which is expectable, but you can see that the people with PSP, despite not having a loss of neuromelanin as their most important feature of their disease, but you can see that the level is much, much lower, also compared with Parkinson's disease. So neuromelanin itself also can, also this MRI sequence of neuromelanin can give us much information. And also and finally, with MRI, we can see what is the state of the iron. Iron is one molecule, one element that is much diffused in the brain, and is important because it attends to many functions, many biological functions in the brain. However, it has been seen that with the age, especially in some areas, iron can be increased. And those areas are the same areas that in some neurodegenerative diseases, such as Parkinson's disease and PSP, it can be much increased. So we can have an excess deposition of iron. And it has been seen that when iron is high, we can also, we generally have an increase of inflammation. And we have seen from the talk earlier this morning that inflammation never is a very good thing in the development of neurodegenerative diseases. With this sequence, with MRI sequences sensitive for iron, there is one that is called SWI, susceptibility weighted imaging, or this one that is called the QSM, the one specifically of this picture. We can also see not only how is the brain from a structural point of view, but also how much and how many of certain compounds, as I said, recapitulating, as I said, from neuromelanin or with iron, also how some of those elements that can be detrimental and very informative to try and reconstruct all the timeline that leads to the development of PSP and of neurodegenerative diseases in general. So this is for magnetic resonance imaging, how we can go from something that we have seen on the neuropathological examination to what we can see in vivo in patients with a disease, so that we can see how all those alterations develop, when they develop, and how they progress, and how do they relate with the clinical symptoms. And this is exactly what I'm going to speak here in the second part. For this second part, I would like to introduce one major player that has been already discussed extensively this morning. That is tau. We have learned this morning that tau is a normal protein of the brain. Actually, it is an essential protein of the neurons, because it is essential for to have a normal shape for the neurons. So if the neurons have that shape, if the neurons manage to communicate from one end to the other end of the cell, it is mostly because of tau. But on the neuropathological examination, we see that tau is all accumulated, all aggregated in structures within the cells that are called neurofibrillary tangles, that, as I said, are composed of tau. In the neuropathological examination, we see that tau is all built up, all clumped in the cell, and we think that the functions of the cell, because of the aggregation of tau protein, are impaired. And this is what we see on the neuropathological examination. So the second, very, very important, the second very promising imaging technique is molecular imaging with positron emission tomography, of which we have already heard something this morning. We have tau that we cannot see in a living person. There is nothing that makes us see tau in its natural position or in the brain in a living person, unless we tag tau with a molecule that we can see. That is a radiotracer. That is an element, a compound that has high affinity for the tau. So when circulating in the brain, it binds to the tau and has a property, it is radioactive. It means that the radioactivity of the compound can be picked by a CT scanner, so that the images that are digitalized and processed by a computer can give us this picture that has a scale of colors, of which the brightest colors are a high uptake of the tracer, so it means a high density of tau, and the darker colors mean that there is little tau in the brain. And so, as it has been discussed already, we can see in a person that has been diagnosed with PSP, or a person with PSP compared with a person with another neurodegenerative disease that can be similar, we can see, for example, a different deposition of tau in certain brain regions, or we can see a different deposition of tau with time. How this correlates with, so how faithful, if I can say, what we see in the picture in the living brain is to what people in the neuropathological examination have described in the past has been demonstrated many times. Here I bring an example from my research group, the research group I am part, and this is actually a person with cortical basal degeneration. This was a study performed 2 years ago with a tracer that is called AV1451. That people with cortical basal degeneration had increased levels of tau in the brain. As you can see, it's very the colors here are very bright. This is the cortex of the so the upper part of the brain. We're actually looking here at this part of the brain. One subject underwent a brain biopsy for another problem, a different health problem, but the brain biopsy was by chance in the same location that showed the highest level of tau deposition in the PET scan, so the brightest region. And you can see that the brain biopsy showed all the same alterations that were seen in people with this disease on the neuropathological examination, and correspond very much to what is seen by the PET scan. So not only we can see in vivo, in a living person, what we have seen until a few years ago only on the neuropathological examination, but we can also rely very much and predict what what and where will be the deposition of proteins in the brain in the neuropathological examination. So the final purpose of neuroimaging in PSP, but also in cortical basal degeneration, is to provide answers from a diagnostic point of view, and this is one very exciting area, but can also be a way to try and answer some of the questions that have been raised by neuropathology, but that neuropathology can't reply, can't provide answers. For example, when does tau start to accumulate in the brain? Is it something that happens early? Is it something that happens only when the symptoms have appeared? Is tau capable to drive the alterations we see in the brain? So is there any correlation? For example, I see this much of tau, does it correspond to this much of clinical alterations? And do they progress over time in a similar manner? And why some areas of the brain are more affected and why some others seem to be less affected? And it has been touched already, a concept of the earlier this morning about the possible spreading of this junk protein tau from one cell to the other according to their connections. And this is something that in PSP is starting to be investigated, but in other neurodegenerative diseases such as Alzheimer's disease, there's already some bulk of literature that shows how the tau protein progresses from one area to the other, and why some areas seem to be more vulnerable compared to others. And finally, which is something that is the most important of all, for example, if we decide to target the tau protein with a therapy, as we have seen there are some attempts already, can we expect to see a change in how much tau is present in the brain, and how can we measure it, and how can we see that tau? How can we see that if tau goes down in any way, we can see that there is a corresponding improvement of the symptoms. In this way, we can imagine all that I have said, so tau, but also all the other neuroimaging techniques that I have described as a potential biomarker. What is a biomarker? A biomarker is an aspect of a disease, any kind of aspect, that can be measured and that can give information about the state of the disease or of the condition according to the quantity. So it is something that tells us, first of all, that if it's changed compared to the normality, it means that there is something wrong going on. If the amount of change is proportional to the severity of the symptom of what is going wrong, and also it can predict at what stage we are of the progression of the disease if measured. If we draw a graph like this one, in which we have the time here horizontally and vertically, here we have the intensity, and this red arrow is the progression of the symptoms over time that slowly progress and become more intense, become more severe. We can think that at a certain point here we have the onset of the disease. And after some time, we have seen from the previous talk by Diane, there is some gap, there is some lag of time between the onset and the diagnosis. We have the diagnosis, and in this period of time, we have a disease that has already progressed a bit. And we see over time that it should be very important to track the progression, as well as to identify the disease, as well as to identify when the disease is progressing. So if a neuroimaging biomarker is able to draw on our behalf this red line, it means that we might know much more about how the disease is, and we can also try and understand what measures on what to target to try and modify the disease. Currently, many studies use potential biomarkers. I anticipate that, unfortunately, we don't have yet a biomarker for PSP, as well as for other neurodegenerative diseases. Some studies, and the most recent studies, also concentrate on this other concept, that is multi-marker. It means that not only one aspect of the disease is studied, but many aspects one another. We have heard from the talks this morning that, for example, the tau deposition can be related to how well or how bad is the level of neuroinflammation, or how the deposition of tau is related to how altered are the synapses of the brain. This is what is meant by trying to understand more than one possible aspect of the disease, to try and understand more about the progression of the disease. And this is also what we are doing in our studies. We have currently 2 studies on patients with PSP. One has just started and is recruiting at the moment, if all the situation allows, and another one will be starting hopefully at the end of the spring, beginning of summer, and both of them will try to understand not only one biomarker but multiple biomarkers, to try and understand what is the relationship and what is possibly the cause-effect relation between them. For example, in the clinical visit, we can understand clinical biomarkers, possible clinical markers, such as the level of disease severity, all the scales, all the questionnaires that we perform to all the study participants, that sometimes can be lengthy, but all serve to gather information, to stratify, to categorize the patients with the disease. Or we can try and do some neuropsychological tests to try and check how is the cognitive status of the participants. And now there are many computerized tools that can provide objective data on this, and we can try with a blood sample, urine samples, so fluid biomarkers, to try and understand what in the blood is altered, what is increased, and what is decreased. And then we have imaging. So what we do is to use MRI or PET imaging, and to combine all those information to try and understand as much as possible, as I said, what phenomena are happening and how they relate with each other. And then we do a follow-up to try and understand the progression of the disease and how all this data that we have gathered progress also accordingly to the progression of the symptoms. So in this way, we can really imagine, we can really think of an imaging biomarker that not only helps in the diagnosis by differentiating between healthy people and people with PSP, but also tracks the progression of the disease, and most importantly, and very importantly, in consideration of what we would like to do with all this data gathered in the near future, trying and understand what happens before what we think is the onset of the disease. This is a concept that has been touched already in the previous talks. In Parkinson's disease, in Alzheimer's disease, we have seen that when a patient first recognizes that there is something going wrong, and for example, some clumsy hands or some problems in the memory, it means that the real process that leads to the disease has been undergoing already since many years, sometimes decades, and we have all the clues, all the possible evidences to think that this happens also in PSP, and trying to move.
So we
Yes?
are running a little late. I know that you
Yes,
started.
I have. Yeah, just to
miss their coffee break.
Yes, so we can assist in the diagnosis, monitor the disease progression, and identify it as early as possible. So we can try and find potential therapies using PET imaging. Here is the research. You can see that the number of studies on PET imaging on tau is on the rise. And we can try and understand two things. First one, we can use PET imaging to assist in the development of drugs. For example, we can use a drug to try and understand how much it binds to the same target of the PET tracer, for example, the tau tracer. But most importantly, we can use neuroimaging for clinical trials for PSP. This is something that we envisage can be used in the future, so that those first trials that have been also discussed early this morning by the use of neuroimaging can help us understand and measure what is the effect of the therapy in PSP. And to do so, we can also try and identify patients earlier and earlier in the disease process, so that we can try and think to be as more effective and as effective as possible if our purpose is to modify the course of the disease. And here I would like to thank all the people, all my colleagues, researchers, all the partners, and also Invico, that is a neuroimaging center that in London that hosts all our neuroimaging research activities. Thank you.
Edoardo, thank you very much. That was fantastic. I'm sorry I had to cut you a little bit short.
Yeah, no, I'm sorry.
But yeah, very interesting. Lots of food for thought. I've just got one question specifically, I think, directed to you. Is the patient that you mentioned that had the brain biopsy, is that an option for other patients to diagnosis, or would you say that might be a bit high risk?
Yeah, no, well, the brain biopsy in that particular patient that I described, that was a sort of a case report in a general study. That patient had another health problem that was unrelated to the neurological problem, and had to undergo a brain biopsy. That was for a different problem. The only thing that was literally by chance was that the brain biopsy was in the same area that was captured by the PET scan as the most affected, so that for this reason it was a sort of a way to try and understand the relationship between in vivo imaging and the neuropathological examination.
Wonderful, thanks. Okay.
Thank you.
Wendy, I've got a few other comments and questions.
Yeah, we have a few other questions that we haven't addressed yet, kind of relating maybe to different talks. So I don't know if people want to go and get a coffee and come back, do. If people want to listen to the questions, then do. So feel free to do what you'd like to do. If you
Before everybody goes, what time are we starting the next session? So
the next session, I think we will start at, shall we do 3:10? So we've had a 10-minute break, but in the meantime, I have a couple of questions that maybe I might ask, and then if people stay around, they can listen to the answers. So there were two questions about, I don't know, this may be relevant to quite a few of our panel. One was about the use of functional ultrasound in Switzerland. I don't know if anyone knows anything much about this and how that, reducing rigidity. Is anyone able to chip in on this?
I might be able to help a little bit, but Hugh, unless you know more about it from the trial structure, I think I know what the question refers to.
I think this might refer to focused ultrasounds, rather than functional ultrasound. So that's a technique which is an alternative for deep brain stimulation, where you can actually change the sort of circuitry, if you like, of the deep structures in the brain involved with movement, the basal ganglia. So that's shown some effectiveness for tremor in Parkinson's disease. In fact, there was a study that came out about 3 or 4 weeks ago in the New England Journal, showed that actually it didn't do that much for the stiffness and bradykinesia of Parkinson's. So far, we don't think that any brain operation techniques like deep brain stimulation and so on have been helpful for PSP. There have been some studies looking at this, but so far it doesn't seem that things like focused ultrasounds or deep brain stimulation are helpful for PSP. And I think, as you know, many speakers have alluded to, it really relates to the sort of circuitry problems in PSP and the interaction between brain areas that we need to tackle, which is kind of illustrated through all of the imaging techniques.
Okay, thank you. So then another question, I'm reading these out because I'm not, hyperbaric oxygen therapy. Anyone, any comments on that?
Yeah, I'd say, yeah, the short answer is it's of no proven benefit, and it's very unlikely for other reasons to be of any benefit. It has a sort of vogue use in various places. It's expensive, it's high technology. People will, I think, on that grounds, put a lot of faith in it, but I would say for PSP, I would avoid it, and I would certainly not pay anything for private sessions. I think you should save your money and use it more wisely for other things that make a difference to everyday life.
Okay, thank you. And then there was another question about, if people have been taking other medications for many years, could that lead to kind of, development of kind of neurological things, or, is there any evidence of that as yet, or is it too soon to say? There was even a recent question about the Biogen vaccine, it's obviously maybe a bit too soon to say, but, what's the thought on that?
Well, so I might kick off, others have their own views, but I think it's fairly clear that there are a lot of medications that can unmask PSP that is there anyway. That many medications that might be used in mental health illnesses, so-called antipsychotics, some antiemetics, anti-sickness medications, they can bring out the symptoms of a disease that's already there. They don't cause the illness, but they might bring it out a little bit more strongly or a little bit earlier, but they're certainly not causes. I would say with anything like a vaccine, when you roll something out and give it to millions of people, 4 million people to date in the UK and many more around the world, this will start to be seen at the time when people are beginning to get their symptoms, and people may try and make a connection between the onset of their PSP and the vaccine. But don't forget the illness of PSP in the brain will have been brewing for many, many years. And I would really urge people to take up the opportunity for vaccination. The risks of COVID to your health, your brain health, and your rest of physical health, I think would vastly outweigh any minuscule risk in relation to PSP itself. So I think the vaccination is really quite important. People with PSP are vulnerable to the effects of COVID.
Thank you. And then there was another comment that came up. I think we kind of addressed this earlier about playing rugby or boxing and head injuries. I think you kind of addressed this earlier anyway, but is there any research going on into that?
Yeah, so in Prospect, actually, we're collecting people's head injury data. I think it's difficult because when you do this sort of thing retrospectively, so you ask people who already got a condition what they've been exposed to in the past, it's very difficult to really compare them with a control group because people tend to recall lots of things that happened to them. We do know that, the type of pathology that's associated with boxing is called CTE pathology. We do know the rate of that is higher in PSP patients. In Queen Square Brain Bank study, as many of you know, patients have very kindly donated their brains to be studied after they've died, which is a really important part of PSP research. And the rate of CTE pathology is higher in PSP patients. Of course, we know that PSP patients fall a lot. So they may have head injuries that are secondary to illness. So it's a little bit uncertain as to whether that might relate to head injuries earlier in life being a risk factor, or it might very unfortunately be related to the number of falls and injuries that PSP patients have as part of their condition. But I think it's certainly something needs to be that is being looked into further.
Okay, thank you very much. Thank you. And I think there was one final, well, there's probably more questions that have popped up since, but one of the other questions was going back to, and I think this came up really as part, I will be touching on this a little bit as part of the new research strategy. This came up within the findings of the priority research questions study, was the kind of emotional and psychological, psychosocial effects of one, you know, having PSP or CBD, but also being a family member or a carer who's either looking after someone who's not getting the right answers, who's being pushed from pillar to post without getting a diagnosis and not really knowing how to get that support you need. And I guess all of these areas are, you know, are underfunded, and you know, I guess what can we do as an association to try and encourage more research in these areas?
So I think I would say that everybody here, I'm sure, is acutely aware of those issues. You know, we see it in every patient that we meet, and the society likewise is very much aware of it. It's just how we address it and how we can best support you in what is a very difficult time of life.
Yeah.
We have collected some data within both the PINE study and the PSP and CBD cohort, which should allow us to look a little bit at care prognosis, or how carers fare over time, because clearly that's essential both for their own health, but supporting their relatives. So that data is there, and we will be able to look at that in detail.
Okay, thank you very much. I think therefore, Alistair, thank you very much. I'll hand back to Nigel.
Thanks, Diane. And Edoardo, we've got some other questions. Presumably we can direct message back.
Yes, I think we'll have to direct those directly to him. Yeah, so that'd be everybody. Great. If you're happy to answer those, Edoardo. Yeah.
Yes.
At a later stage, great, because we're just running over. Okay, what we're going to do now is I'm going to pass back over to Nigel Leigh, who will introduce the final session of the day. And this is the session where, after I've introduced the new research strategy, we all get to have a little interactive session, play a game, well, answer a few questions anyway. So do stay around. If you need to go and get a drink, do pop up and get one. But do come back and stay around for the end of the session with the interactive bit. Thank you.
Okay, thank you very much, Wendy. I am introducing you to lead this session. Just like to say that, as I said to begin with, I'm new to this organization in terms of participating in the research committee. But it was evident the day that several days before I even started on this, that Wendy had done an extraordinarily proficient job in putting together the consensus and the communications with members, the scientific community, the people affected by PSP, to get this research strategy together. And I felt very spoiled as someone on the research committee to have this foresight and synthetic view. I think this will serve us extremely well. Of course, it's adaptable. It has to be, we have to be flexible for the future. I think that's inherent within the strategy. But I'd like Wendy, who has led this and done so much else for the association, to explain it herself. So please.
Thank you very much, Nigel. That's right. Oh, now it's my turn to share the screen. So, which I managed to do it quite easily earlier, and now I'm struggling. Okay, can everyone see that? Introducing the new research strategy, which was formally approved by our Board of Trustees towards the end of last year, and also approved by our research committee as well. So just want to give you a little bit of a background as to why we developed this new strategy. So back in September 2019, there was a need to identify a new strategy because the current strategy of the association was due for renewal. And of course, as we know, one of the key charitable purposes of the association is to promote and sponsor research. And so therefore it became quite crucial that this strategy was put in place. At the time, the chair of the research committee was Hugh Perry, and so Hugh and I worked very closely together in developing this new strategy to take the organisation forward. So this is a little bit about what we did. So in October 2019, we identified key stakeholders to engage with, and it was a very wide consultation process. I felt that everyone needed to be engaged, everyone needed to be part of this process, because the research that we were looking to support would involve patients at the heart of it, but also obviously very important to involve the scientists, researchers, health professionals and other related organisations. So in order to do this, 4 documents were prepared. Many of you, I hope, on this call will have completed maybe 1, 2, or perhaps even 4 of these documents. And these were circulated to our members and to research and health professionals to complete. And alongside of this, we also undertook a research impact survey, which is something that looks at the research that has been funded by an organisation to see what actually the impact of that research has been. So again, this is an important part to feed into a new strategy, because you want to check to see if what you've been doing previously has been worthwhile, if it's met its goals and objectives, and if that is something you want to carry on doing into the future. So all of that information was collated through this consultation process. And alongside of this, people were also asked to think about what areas of research were important to them. So this information was all gathered together in order to come up with the new strategy. So in January 2020, the consultation ended. We had around about 130 completed questionnaires from a range of people: patients, carers, health professionals, researchers, scientists, trustees, staff. And then we also gathered through a slightly different process what we'd like to call our research priorities. Now, this list came up with around 2,000 priorities, but I want to make it clear that although there were 2,000 priorities, many of these do overlap. So the priorities that are identified for research by patients, by carers, by health professionals, many of them are very similar and actually overlap. And this data still needs to be analysed, and we're hoping to work on this project this year as one of our priorities. We also collated information, as I said, on research that we funded in the past and how successful we felt that funding had been. So these are the findings of the consultation process. What the research questionnaires found was it identified these different themes which were important to people. So awareness, diagnosis, living with PSP and CVD, the prevention of PSP and CVD, causes and treatments. These were the key themes that were highlighted from all the questionnaires that were sent out to patients, carers, researchers, health professionals. And as I just mentioned before, we also asked for people to say what their research questions would be. So just an example, it might be, well, you know, if I do exercise every day for 5 minutes a day, will that improve my symptoms? So that's one example. Or if you know, are there particular treatments that could be help with my symptoms, even if it's not related to kind of you know, finding that particular cure. So all of these questions have been identified, and will need further analysis over time. And then finally, just coming to the results of the research impacts survey. So we sent this survey to 20 researchers. We heard back from 12 who'd undertaken 22 different research projects that were funded by PSPA. As we know, PSPA is one of the UK's only research charities dedicated to funding PSP and CBD. And the results we found were that over the last 25 years, 75 publications have been printed in peer-reviewed scientific journals, which are directly related to research funded by PSPA. We identified 18 researchers who've been funded and who now lead very important research studies across the UK. Many of them, some of them who are here today. So it's nice to welcome you here. And of course, you know, one of the key things that's come out of today is this collaboration between researchers across the UK, but just also internationally. It's really important in a rare disease that collaboration takes place at an international level. And finally, one of the key findings from this survey was that actually PSPA-funded research acted as catalyst for researchers to get other funding from major funders such as the MRC, Wellcome Trust, National Institutes of Health Research, and many more. And this is where charity funding research is so important, because something like a recent study showed that over 40% of the research in the UK is funded by medical research charities. Now, that is a massive proportion of research that is going on within the UK. And it's very important that as a charity, we continue to fund research going forward, and we continue to make a difference to people with PSP and CBD. So the findings of all these different questionnaires, consultations, and surveys were all brought together and culminated into our new research strategy, which I'll present now. So the strategy itself comprises of 4 strategic elements. The first being prioritising PSPA research. We want to be able to support new research ideas in a responsive manner, but we also want to focus on what our patients, our carers, and our members found to be the key themes and the key areas that they want research to be undertaken in. So alongside being responsive to any new research ideas, we also want to focus our research funding on the prevention of causes, awareness and education, improved diagnosis and reduced misdiagnosis, drug discovery and targeted treatment for underlying causes, and improved interventions for the treatment of all the symptoms of the conditions. So, you know, improving people's daily lives, as we talked of earlier, is ensuring that, okay, yes, we may be looking for these treatments of the future, but we want to ensure that people living with the condition are supported and helped at this time. And that all these research themes should enable a patient to live the best they can with PSP and CBD. So our second area of focus for our new research strategy is career development. And this again came out of the findings of our research impact study that showed that close to 18 of the researchers that we had funded in the past have gone on to set up their own research groups in PSP and CBD, and actually many of those centres have now become renowned worldwide and globally for research into PSP and CBD. So we want to continue doing this by funding the research stars of the future, as we call them. So new researchers who are just embarking on their careers in PSP and CBD research, just starting by doing their PhDs, and will become, we hope, the academics of the future who will lead the way in finding treatments and improving diagnosis for many decades to come. And then the third strand is something we'll focus a little bit more on after this session, and this is where our little kind of interactive session comes in. So we want to engage patients in research going forward. We want to ensure that their voice is heard and that they have a say in what research should be funded, how research should be shaped, and that they get an opportunity to take part in research. So I'll focus a little bit more on this later. And then finally, our fourth strand of the strategy is based around communication, collaboration, and change. So it's great, you know, it's all very well to fund research, but if you don't communicate it and you don't bring those findings to the people affected by the conditions, then as a charity, you're not really supporting your members and your donors who've actually raised money to fund the research. And again, you know, today is a good example of that. We're communicating our research today. We're bringing research to our members and sharing those findings of research funded by PSPA, but also other research that's being funded across the UK. So I do thank you everyone again for presenting today. But we also want to be able to work collaboratively as well, work with other research institutions, other charities where there's overlap with our condition. So Parkinson's UK is a good example, where we can work together and hopefully fund joint research projects going forward to look at tau pathology, for example, which is a good example today. And finally, which relates back to our discussion around misdiagnosis or lack of early diagnosis, is that we have to be at the forefront of lobbying government agencies and NHS commissioners to make changes in the clinical pathways available to people with PSP and CBD. And this we've started already recently working with the Neurological Alliance, who have just released a paper called Out of the Shadows, which is looking at rare neurological conditions. And we've been lucky enough to be part of this, and PSPA has been featured very strongly in this because of our involvement. So these are the key areas that we're looking at to address going forward. Obviously, we can't do it all in one go, so we have to take it step by step. So for 2021, these are the objectives that we've highlighted and hope to achieve, that we'll continue to fund vital research in these key areas identified by our members, that we'll launch our Patient and Carer Voices in Research Network, which we will do in 5 minutes time. So that's all rather good. And we'll identify the top 10 research priority questions for PSP and CBD. So thank you for your time, for listening to that. I'm happy to take any questions. Thank you.
Thank you very much indeed, Wendy. I think we've got a couple of minutes for questions, and then before I go on and bring Carol Amirghiasvand into this as well, who I should say has played a very important part in developing this, as well as many others in the PSPA office. But let's just see if there's any. Wendy, will you?
I have the questions, don't I?
You answer your own. Well,
I'll answer my own questions, shall I? Yes, just hold on one moment. I think everyone's happy to move on. Actually, we do have one or two questions, but not specific to the strategy. So I think we can move on.
Yeah, I think if there's any pressing questions at the end. So here's Carol, and you two together. Carol, are you going to say something separate, or are you going to do this?
I think we're doing it as a together.
I think we are, yeah. So I'd like to introduce Carol. She's helping support the patients and carers research network today, and we're going to do a joint presentation. I shall be kicking off, and Carol will be launching our quiz. So be ready with your computer mouse or your laptop, your screens, because we're going to be asking you a few questions, and it's going to be interactive, and we'll show you the real results at the end of it. Anyway, so yes, we'd like to today launch something which has always been part of PSPA. It's not something new, but it is something that we want to grow going forward. So many of you who are on the call today will already have signed up to participate in research by filling in one of our online forms. And what we're wanting to do is create a more a kind of wider package for people to get involved, not just in being part of a trial, but also to help shape research going forward and have a voice in research going forward. So today we're launching, as well as launching the research strategy for the first time, we're also launching our Patient and Carer Voices in Research Network. And I'm joined, as I say, by my colleague Carol, who's Director of Engagement at PSPA. So again, just referring back to the research strategy, I won't go into detail, but one of the key themes that came out of the consultation was the need for patients to be involved in research. So we really want to support research which reflects patients' views and priorities and encourages them to take part in research by giving them a voice. One of the other things we want to do with our kind of research voice network is to educate members and local groups about PSP and CBD, and to support the helpline team in answering research related questions, which we have been doing again, but this is more formal part of our strategy. And we want to continue and to work with pharmaceutical companies, many of whom now are very keen on engaging patients within their patient advocacy work. So now is the time really for us to push ourselves in that direction too. So in order to do this, what we'd like to do is get more and more people involved in research. So we want to give patients and carers a voice to help shape research projects from the very beginning, to help identify questions that patients and carers would like answering, and to ensure that PSPA research reflects their views and enables them to take part in clinical trials and any other research studies that are ongoing around the UK. Now, we've mentioned a few of these today, for example, the Prospect study, which is funded by PSPA, and the OPSQUIT study. And Edoardo is just starting a new study in London. And so there's a number of studies that we can actually put people in contact with the researchers for if they're interested in finding out more about getting involved in research. So in order to do this, we thought we'd do a little research poll. Now, if you are finding it a little bit difficult to use the technology, then what we can do is we can always email you the questions out at a later date. But if not, I'll hand over to Carol, who will talk about our research poll.
Thank you, Wendy. Thank you. Yeah, Debbie, I think, is going to launch the poll now. What we're going to do is you'll answer the questions today, and we'll give you instant responses. We will take away all of the information you've given us, and of course feed back to you over the coming weeks. Now, we were a little bit concerned that those of you on iPads may not be able to see the poll very clearly. So I'm going to read through it. I'm sorry if it's going to be me just talking and reading questions, but I think if you can manage to tick a yes or no, or I wish not to answer comment, that would be really good. If you can't see the question really, really clearly. Majority of questions are single answer, some are multiple choice. So I'll let you know when you've got a multiple choice one. So fill it in your own time if you want to, but I will go through the questions now. So question 1 is, have you ever participated in a research study? So you have yes, no, or I wish not to answer. So I'm going to fill mine in now. I think you click on the no, Wendy. Yeah. Number 2 is, have you joined the PSPA Patient Network, recently renamed the Patient and Carer Voices in Research Network? You've got yes, no, and I wish not to join, no, but I would be interested in joining. Question 3. If you answered yes to question 2, when you were approached to participate in a research, were you approached to participate in a research study? And you've got yes, no, I did not choose yes in question 2. Question 4 is a multiple choice question. So what type of research study would you be interested in participating in? And the options are: helps to find treatments, would lead to better care, would lead to earlier diagnosis, would improve patients' quality of life. Number 5, again, is a multiple choice question. Which of these areas are most important for researchers to study, in your opinion? Misdiagnosis, improved care provision, prevention of PSP and CVD, treatments for PSP and CVD, mobility and exercise. Question 6, another multiple choice question. Would you like to support PSPA by supporting the design of a research study, being a part of a research study, i.e. as a study participant, speaking at future PSP events about your experiences, that's events such as these, or family and friends days, or study days, sharing your personal story in our magazine, PSPA Matters. The final question is a single option. If you would like to hear more about the work of PSPA, please enter your email address in the chat box. And thank you for participating. And you've got yes or no. And that's the end of polling. Okay. So we need our results, share results. Okay. Do you want me to run? You can run through these, Wendy.
Oh, I don't know. You were so good at asking the questions.
Okay. Okay. So, 65% of you have never participated in a research study, but 35% of you have, which is good. Is good. The PSPA Patient Network. Some of you have already joined. 35% of you have, and a small amount of you, 10%. Oh, that it's gone up now. Let's see. Yeah, 10%. No, they didn't wish to join, but that's fine. And 55%, Wendy, are interested in joining. So that's good.
Really pleased. We'll make sure that we get the information to you.
Yeah. If you answered yes in question 2, have you been approached to participate in a research study? So the ones that actually have registered with us, yes, 20% of you have been approached, but sadly 25% haven't. So I'm not sure. We need to look into that, I think. Or
yeah, follow up on that.
Yeah.
More information, yes.
The 4th question was, what type of research study would you be interested in? At the top was, of course, help to find treatments, 90%. 80% improving quality of life, 60% would lead to earlier diagnosis, and 70% better care. So
it's great. I think generally kind of covering all those areas, which is really positive.
Which of these areas are most important for researchers to study? Treatments for PSP and CBD, 95%, of course, that's what we'd love. Prevention of PSP and CBD, 75%. And then 3 at 35%, mobility and exercise, improved care provision, misdiagnosis. And 6, would you like to support PSPA by? Lots of you would like, 85% of you would like to take part in a research study. And we will do our best to push you forward for those if you register. 50% of you supporting the design of a research study and sharing your personal story. So again, if you are interested, pop your email address in the chat. And 35% of you speaking at future PSP events about your experiences. That's really, really great news.
It's really positive. No, thank you for everyone for responding so positively to those questions. That's really great.
Right, thank you. I'll pass you back to Wendy for a moment.
Okay, I've got to work out how I close this.
I think we just,
there we go. Yeah, so what we're intending to, that's really useful information, and I think what it shows is that actually, thank you. Finally, have I done that little line across my screen? I don't know.
Worry.
Anyway, there we go. Finally, as part of our kind of little offering today, I'll hand back over to Carol, if I may, because I think one of the things that came up earlier, particularly when we were talking about diagnosis and misdiagnosis, is around raising awareness, and again links very closely to our research strategy about awareness, about misdiagnosis, about lobbying, about campaigning for change. So I'll pass over to Carol to fill you in on what we have planned for just over a month from now.
Thank you, Wendy. As you know, PSPA always do amazing campaigns throughout each year to raise awareness of these conditions. And following Ed's research paper in 2019, it was decided that we would pick up on those 10,000 people that could be living out there with PSP and CBD and use this as a campaign for 2021. Now, the 10,000 people living with PSP and CBD is the same number as MND, yet PSP and CBD are still relatively unknown. So we hope that throughout the year we can do as much awareness raising as we can to rectify that. So our 10,000 Voices campaign aims to raise awareness of these conditions amongst health professionals and the general public, so that more people recognise the signs and symptoms earlier, which we hope will result in earlier diagnosis and people referred on to the appropriate care and services and support. Our 10,000 Voices campaign will be a team effort, PSPA staff, volunteers and all our supporters. We will be launching the campaign on Rare Diseases Day on the 28th of February. And on that day, we will be calling for people to lobby their local MP, share our red flag posters with your local GP practice, and also share your experience of PSP and CBD with us here at the organisation, so we can post on all our channels, social media channels and our website and our magazine. Now, if you are interested in joining us and helping with this campaign, if you could email the communications@pspassociation.org email address and talk to Helen about it, she will get things across to you to help you. We will be doing also some fundraising events throughout the year to coordinate with all of this, but our main focus on Rare Disease Day is to launch awareness raising. So thank you, Wendy.
Thank you very much, Carol. I think it's going to be a really, really exciting campaign, and I really hope as many of you as possible we'll get behind it, and let's shout out for PSP and CBD and make people more aware of it. So thank you. Okay, well, I think we are coming towards the end of our day. I will hand back over to Nigel to do the kind of final roundup and thank yous. But I'd just like to thank everyone for being so responsive when I contacted everyone about the day, and thank you very much for all your support. Okay, I'll hand back over to Nigel.
Well, thank you very much. And all I've got to do really is thank you, Wendy, but also the team, and I'm sure there are others. I want to mention them. Debbie Benedy, who's the office, one of the office managers, Carol, who's taken us through the questionnaire, Jill Dixon, who I know has helped a lot, Scotland manager, Charlotte Rook, Trust and Foundation manager, Helen Chapman, communications, and Julia Brown, who's the helpline team leader. So all of those have contributed to this, in my eyes, very successful day. And I really hope that it was successful with the people who have joined us, asked questions, some of which we have not yet got the answers.
Yes, we will get to them, yeah.
But certainly, I think our speakers have laid the foundations, or articulated the evidence that suggests that things are moving forward, as I said earlier, much more rapidly than they have done in the last decade or two, certainly 2 decades. And we can see that it's going to speed up over the next couple of years. And every year, as I think James, one of us said, maybe it was Hugh, we realize how painful each of those years of delay is while we work on this. And you're absolutely right, I'm sure, to ask those hard questions. Why aren't you doing it quicker? And I think we'd all say we'll do our best. Well, it'll be other people more than me. So the speakers we've had are really at the top of their game, and it's wonderful to see these very active groups, individuals who are taking this forward. It's very reassuring. There will be more trials. There will be more opportunities to take part in research. I have no doubt about that. So I think that's enough from me. A big thank you to everyone. If anybody wants the last word, they're very welcome to have it. It could be Wendy or anybody. But
I think I'll just say that yeah, we'll be in contact with everyone who shared their email addresses with us. If we didn't get around to answering your question, we will do our utmost to answer your questions. And I hope you've all had an enjoyable day. And thank you everyone for joining us today. Thank you.
Goodbye. Thanks very much.
Thanks so much.